Okay, guys, here we go. So this is going to be the second kidney lecture that we need to go over. So this is nephron reabsorption and clearance. So really all you got to know from this lecture is what is reabsorption, what are the mechanisms by which reabsorption occurs. So if you remember, we first had filtration, right? That's everything being dumped out of the glomerulus. So let me actually move forward 2 slides. I'll come back to the objectives, but then just look right here at the glomerulus. So filtration occurs here. Stuff gets originally dumped from the glomerulus into Bowman's capsule. Then it can start making its crazy path all the way through this nephron. In last lecture, if you guys remember, this nephron actually is folded up on itself. So it's not linear like this, right? It's all together. Like if we were to compact everything, it'd be like a quarter this size, all compacted in a 3D space. So that's kind of important for the tuboglomerular response. I can never say that right. But the fact that the macula densa cells of the DCT right here can talk to the afferent arteriole, that just shows you, hey, this isn't all the way over here. This is proximal, I'm so sorry. The DCT all the way over here, it actually can fold back on its own nephron and talk to it. So let's go over the objectives for what I want you guys to get out here. So review key points. We kind of just did that. I want you guys to have the picture of the nephron in your head as we're going through this lecture, okay? That's what's going to be the most important part to understand the reabsorption. Why do we talk about sodium so much? So sodium, it's going to have a couple slides in this lecture, and hopefully by the end, it's very apparent to you why sodium is so darn important for kidney and reabsorption in general. So it's the main mechanism that drives reabsorption is the movement of sodium. We'll talk about how that happens. Understand where and why reabsorption happens in the kidney. So I was looking over what you guys need to know for the final, and this study objective I should have taken out. You don't really need to know specifically the differences in each section like I promised in the last lecture. I'll cover them very briefly just so you know. For those of you who have to take the MCAT or any of those graduate level courses, not courses, I'm sorry, those tests, they do specifically want you to know the different portions of the kidney. So I'll just cover it very briefly for those of you who will be taking the MCAT. And I don't know if it's on the DAT. We should ask someone else. But describe and understand different renal clearance markers. So really all you guys need to know is inulin, glucose, and urea. These are classic markers that are used in clinic, in testing to understand how the kidney is functioning. Maybe not urea, but inulin and glucose for sure, okay? So we're gonna go through all those pathways. I need you guys to know that. And the last thing is understand saturation of reabsorption in the kidney. We briefly talked about this last lecture with how glucose can reach saturation if your patient has diabetes mellitus, right? We'll go into exactly what that looks like too. So let me give you just a big heads up here. So what's going to be covered in today's lecture is not specifically showing up in any 1 or 2 questions on the final, but understanding reabsorption and active transport and passive transport of these molecules is vital for some of the questions I'm seeing on the final, okay? So I don't think I'm giving anything away by telling you you need to know this material, because the next couple lectures in the kidney gets just more involved, you guys. So these first ones have kind of just been opening. For those of you who haven't taken anatomy, maybe this has been really good. For those of you who have, it's been a good review. But we're about to get into hormone regulation and acid and base composition in the kidney in the next couple lectures. So I need you guys to understand this, okay? So take the time, review this video if you need to a couple times. So we already did the nephron. I hope that this is in your head, right? So we had this question today, where are the macula densa cells? Well, we're taught that they're up here in the DCT, but apparently they're also here. Whatever, it can fold back in on itself. That's not super important to know, but macula densa cells are out here. And that would leave what kind of cells over here if we're talking about the JGA, the juxtaglomerular apparatus? Do you remember? It's going to be the granular cells or the juxtaglomerular cells right here, okay? Okay, let's move in. So why have such a high glomerular filtration rate if the kidneys are to reabsorb almost everything? So let's think about that again. So last lecture, we learned that only what % of the blood is actually filtered? Do you guys remember? Okay, it's going to be 20% of the blood is actually filtered. Okay, then what's actually excreted from that filtration? Well, that's like almost 1%. So why are we allowing the kidney to get rid of so much stuff if it's going to take us energy to get it back in? Well, the short answer for you is it depends on our environment. So take say for example, you are super dehydrated and you're in the middle of the desert. All of a sudden, all this water and sodium that was pushed out, you're going to want to take that all back in, right? You're going to be taking everything you can get if you're all stuck like that. But if you have plenty of water and you're in a hydrated environment, your body's not under any stressors, then that extra water and um, solutes in the water is actually going to be able to be excreted because your body doesn't need it. So the kidney is, I think of it as like a retirement savings account or like some backdrop savings. So it really can keep your body in metabolic balance. So if you need it, it's there, you can reabsorb more. If not, get rid of it because it was just taking up other space in your bloodstream and we really want to regulate blood pressure, okay? Okay, hopefully that makes sense. So sodium reabsorption in the PCT. So this is what I said was key. This is gonna be if you can understand this, I think the rest of this lecture will work just fine for you. So one thing I wanted to say is the difference between the apical and the basolateral membranes. If you guys see this slide, this is on I took this directly from one of Dr. B's slides. So it says it right down here. Sodium is pumped out the basolateral side of the cell. Just remember the basolateral is facing in and the apical side is facing out. If you guys forget that, think of your like skin. The apical side is facing out, it's facing the environment. The basolateral side is facing in, it's connected to that connective tissue layer. So apical side in the lumen of the kidney, basolateral side is going to be more inwards, extracellular right before. And then you would say like, oh, well, if this is the interstitial fluid, then the capillary must be like right along here, right outside this picture. Okay, hopefully that makes sense. So what happens here is that sodium, when it's in really high concentrations, it can be taken up right here. Okay, so that's just following a concentration gradient. That's nothing special, right? So we'll just look right here. Sodium enters through open channels, moving down its electrochemical gradient. So do you guys think that's active or passive transport? Okay, well, I hope that you guys are trying to understand, well, it's moving down its gradient. I'm going to go with passive transport. I don't need to use energy to get something to move down its gradient. I would need it to get it to move against its gradient, right? If sodium needs to move against a gradient, I need active transport. And that's what's actually happening over here on the basolateral side. So this is just your classic sodium potassium pump, and you're pushing all the sodium back into the interstitial fluid. And why are you doing that? To keep it low in here so that the sodium can just diffuse. We're not going to say diffuse, I'm sorry, that's a bad word. So it can just passively move through a channel. So yeah, I'd say facilitated diffusion, that's fine. Diffuse by facilitation of this membrane, this channel right here into the cell. Okay, and then now that allows us a gradient that we can follow. Now we're going to start to actually hijack this pathway of high sodium to low sodium to high sodium, no energy needed, energy needed. So please review this picture. This is the best picture I could find in the book and online for understanding the basics of sodium. And just know that right here, you don't need to know what it's called, but they are sensitive channels on the apical membrane. So if sodium's low, you're going to get less sodium reabsorption. The membrane channels aren't really going to be open. And if you have more sodium, you're going to get more sodium reabsorption. Okay, it's that simple. Oh, sorry, one sec. Okay, um, okay, glucose salvaging. So this is what I said. We're going to start to steal that sodium electrochemical gradient. So what happens is glucose, any glucose that's filtered, which is only 20% of the blood, any glucose that gets filtered actually gets reabsorbed unless you're a patient with diabetes, which we've talked about so many times. So what happens here is you actually have a different transporter. So it's hijacking it. So still pay attention here. So we have the sodium high, sodium low. That's just what we saw before. Okay, now we have glucose in low concentration and glucose in high concentration. So glucose needs to move down its move against its electrochemical gradient, right? So glucose actually should want to come out of the cell. Well, good news, it can't do that, right? Because glucose is a very polar molecule. You need specific channels to let glucose go and in or out. And this channel is a symporter, right? So glucose and sodium in the same direction. If it was an antiporter, that'd be a good example of this. Sodium one direction, potassium the other. So this is a symporter, which only allows sodium in, and there's a binding site for glucose as well. So sodium and glucose come in together. So glucose can kind of bypass this electrochemical gradient by using sodium, okay? Okay, that's key. So understand this first half. Now let's get to the second part. So we don't just want the glucose to stay here. We need it back in our blood to actually go fuel the rest of our body, right? So what's going to happen is the glucose now just gets pumped out, and this is just facilitated diffusion. So like I said before, you need a specific channel on the membrane to let glucose go either direction. So now on this side, it's just following its electrochemical gradient from high to low. And same as last time, we have the sodium being pumped into the extracellular fluid and potassium coming back in. Okay, so that's maintaining your electrochemical gradient, allowing this to happen. Okay, do I have any questions up to this point, Ryan?
No, you're good.
Okay, we're gonna keep going then, you guys. Brian's the only one who got on, so everyone else doesn't like my lectures as much. Okay, let me get going again. I'm going to skip these questions. They're on Dr. B's slides. You guys can go through them. I'm pretty sure the answers are there too, but I don't even think I've talked about this, so I think it's unfair if we do this question right now. Okay, urea. So I'm going to try and do something really cool here for a second. It might really screw up the video, but I'm going to come over and try and just one moment. Give me just a sec here. Trying to move over into my iPad that I borrowed from the library, which was so generous of them to let me do that. Okay. Okay. Can you see my iPad, Ryan?
Yeah, I can see it.
Okay, perfect. Okay, so how about now? I think I clicked off it. Is it still there for you though?
No, now it's just the slideshow.
Oh, shoot. Okay, one sec. Okay, is it back?
Uh-uh. It was only there for like a split second.
Oh, shoot. Okay, one sec. I'm gonna do it again. How about now? Is it back on screen?
No.
Oh, shoot. I'm just gonna have to do it all over again. Okay, one sec, you guys. Sorry about this. I think it's going to be really helpful. So let me just start talking about urea. So what you need to know from here is that urea is confusing. Okay, so this is this is actually the second of the markers that I said you need to know for this class. And did I lose my Zoom video? There we go. Share screen. Sorry, you guys can skip through this section at 2x speed until I get this to come back up.
I can see your iPad now.
Okay, I'm not going to click off it. We're just going to go with that. So urea reabsorption, I'm going to come back to this in just a moment, but I'm going to try and draw this out for you first. Oh, no, that's not what I want to do, but we can get back to it really quick. Okay. Oops. That's not helpful. There we go. I think I found it. Okay, well, it's not going to work. I'll try and figure out for the next video. I feel like I've wasted enough of your guys' time. So let me hop back into sharing my normal PowerPoint and hopefully we can work through this. Okay. Okay, so urea reabsorption. So everything in yellow here, that's going to be the tubule, right? So you have the glomerulus. Everything in here is going to be dumped if it doesn't get reabsorbed. And then you have the capillary, the vasorecta capillary that's following the nephron. I would know that term, not for this test necessarily, but maybe for the MCAT or any other test in the future. So what's happening here is that the urea is actually going to be taken. It's going to be filtered out just like anything else would be, just from the GFR. Whatever's in the filtrate will be equal to the plasma concentration as well. So how do we get urea back in? it's kind of a cool mechanism. So let's start with sodium, where we always, always, always should start when we're thinking about how things move in and out of the kidney. So we have sodium, sodium chloride that gets to move through. So we already talked about this. Sodium plus moves through, and we talked about this mechanism, right? So it's secondary active transport, and then the sodium potassium pump. So what happens there is you have the less solute in this area here. So the concentration originally that gets filtered should match what is in the capillary. So original concentration at Bowman's capsule is equal between the plasma of the blood and the liquid in the kidney. So when you start moving sodium out, when you're using that that energy to move sodium out, all of a sudden you have less osmoles over here and more over here. So then what's the next thing that's going to happen? Well, H2O always moves to an area of higher concentration. So now you lose water, not lose necessarily, you reabsorb it. Sorry about that. Reabsorb water back into the capillary. So now sodium's come in, water's come in. What's left? Okay, so now the volume has gone down, but no urea has moved. Volume of water has decreased, but urea has not. So say, for example, if the original concentration of urea was like 100 millimoles, 100 millimolar, right? Then all of a sudden when this water moves out, it could jump to maybe 150 millimolar or 200 millimolar. So originally it was 100 in here in the tube and 100 in the capillary. Now it's like 150 over here and probably like 100 back over here. It would be diluted a little bit, but this water change isn't going to do much to the capillary. So all of a sudden now urea has a gradient to move down. Urea is actually a nonpolar molecule that can just be reabsorbed that way. So what you guys should take from this is whenever you reabsorb a lot of water, whenever you reabsorb a lot of sodium, you're also going to reabsorb urea. Kind of just comes through, and it will just get passively reabsorbed. There's no active transport involved with urea. Okay, I think that was the question from the last slide that we wanted to cover. Okay, I was going to draw this out for you because I thought it'd be helpful, but I could not get my iPad to work, so I'm sorry about that. We're going to just move on from there. So this is the next thing you need to know, saturation of transporters. So this is super important for glucose. It's not important for inulin. We haven't talked about that yet. That's in like 2 or 3 slides, so don't worry. And it's not important for urea. And why is it not important for urea, saturation of transport? Well, that's just because urea isn't transported, right? It can just diffuse back in if there's a gradient because the water and sodium's already moved. Okay, but it's super important for glucose. So the plasma concentration is equal to the initial transport rate of substrate. So that just means that what you have in your plasma, you will also see in your kidney at the filtration step. So if you were to take a sample just from Bowman's capsule and just from the capillary, the blood glucose would be equal to each other. It's just diffusing, right, to equal out. But then what happens is glucose is such a great energy source, the body never lets it go. So it doesn't really have a mechanism to stop it from going, right? Because we just have junctions, big gaps in between the endothelial cells, and glucose can get through just fine. So it can't stop it, but it can bring it back. And so it does that by using the sodium system that we saw earlier. So secondary active transport, because it's taking advantage of sodium's electrochemical gradient. If you didn't understand that, I encourage you to go back and watch that portion over really quick. But what can happen is if we have too much blood glucose, all of a sudden we reach saturation of these transporters, the symporters of the sodium and the glucose. So all of a sudden, say I have 6 milligrams per milliliters of glucose in my blood, I'm only getting 4 back. That means I have 2 milligrams per ml in my urine. So this is why you can do urine glucose testing for patients who have diabetes. Okay, so hopefully that makes sense. I think that's pretty intuitive, right? If you've been into biochem, you've learned a lot more about like Michaelis-Menten equations and enzymes than you will have to know here. There's no like reaction that's happening, it's just moving something across. But I thought that was interesting. So normal blood glucose after eating is around 200 mgs per deciliter. That's only about 2 milligrams per deciliter. So you're here. And fasting blood glucose is about 100 mgs. So you're all the way down here. Your kidneys can handle that just fine. So you have to nearly double that to start having some issues. Not even double, you have to go more than double to come out to like 5 milligrams per ml. Anyway, sorry, I think I'm going off track, but just know that we can handle our glucose pretty dang well. Okay. So I have a question here. So if you eat a lot of glucose, would that happen? And the answer to that is actually no, right? So maybe if you literally just sat there spooning straight table sugar into your mouth for a couple minutes to longer, you could actually get some glucose in your urine. But a healthy individual has such a strong insulin response that their plasma is never going to get that high. So if you're doing that day after day after day, year after year, just eating that sugar, then all of a sudden your insulin response goes down. And we can talk about why that happens. It's for a variety of reasons. It can have to do with your liver. That's not a part of this at all, so don't get caught up on that. But hopefully that makes sense. That should never happen unless you have a disease such as diabetes mellitus. Okay. So let's move on. Okay, so this is just some more charts. Hopefully they make sense if you read through them. So plasma glucose, okay, as it goes up, we see filtration rate of glucose going up too. That's intuitive, right? So whatever is in the plasma gets filtered. That's true for pretty much everything. Everything we know in this class at least, right? If I have 300 mgs, it's gonna be equal between the plasma and the kidney flow concentration. So what actually happens here though, if plasma glucose, once it gets to 300, all of a sudden you're excreting glucose. So this means it's coming out at the very end. So this is after all the reabsorptions has occurred. And it's in a linear line. It's at the exact same slope. So once you hit 300, once you hit saturation, all of a sudden glucose is just coming out and there's nothing you can do. Okay, this is just showing what we've already gone over. I don't want to confuse you more with graphs. I feel like you guys probably get it, but let me know if you don't. I think that we've beaten this down. There's normally no plasma is cleared of glucose, rather is fully reabsorbed. Glucose is not getting out if we don't want it to. Okay, this is kind of important. So clearance, renal clearance, is the volume of renal plasma cleared of a substance per minute. I don't like this definition. Let's just go look here. You do not have to do any math portions on the final for this class, but this is a really, really, really good equation to know. For example, if you ever go take the physiology of drug mechanisms class, you have to do this multiple times on those tests. So all that we're saying here is that the clearance of the kidney is going to be to the urine flow rate, so how much urine is coming out per minute, times the concentration of whatever, let's say it's penicillin, okay? The drug, the antibiotic penicillin. So flow rate times the urine concentration, how much penicillin is in your urine. And then we also have, and you divide that all by the plasma concentration of penicillin. That gets you your clearance. So you don't have to do math with this, but I would try to know, to be able to draw this out. Like, I can try drawing it out just here with my, it's not going to be pretty, but we'll do it. So clearance is equal to urine flow. That's just going to be UF. I don't think that's technical, but that's what I'm going to do it for. UF times concentration of the urine all over plasma concentration. So don't freak out, it's not on the test, but this is a relationship I would be familiar with though. Even though you're not doing calculations, I would know, hey, what happens if the plasma concentration goes up? Is my clearance up or down? If this goes up, so know the relationship between these variables. I'd say that's true for nearly every class you take, and that's going to get you much farther in life. Let me get back to this and let's move on. Okay, inulin, this is the last of the 3 molecules you guys will need to know. So what happens with inulin, this isn't, from my understanding, this is not something that we create normally in our body, but it's a compound that doctors or whoever the practitioner is can give to their patient to drink, and then whatever they put in, they know should also come out. So inulin is filtered at 100% and not reabsorbed whatsoever. It's kind of a really cool molecule for that, okay? So the amount excreted equals the amount filtered. So why would you use inulin? You're using it to test what is this patient's GFR, at what rate is stuff being filtered. So if I have 500 millimolar over here, and 500 over here, I can say, well, everything got filtered, which that wouldn't happen. It'd actually be a different number. But what inulin, when you think inulin in your head, I want you to write on your notes, if you're taking notes, inulin is equal to um, amount filtered or filtration rate of the kidney. So you couldn't use other molecules like glucose because glucose is really reabsorbed. Urea just depends on other things. So inulin is great because it does not get reabsorbed in any way besides just being there, right? Okay, so inulin, super easy. This is a test that the doctors, practitioners will always get, not always, sorry, will give to their patients if they think there might be kidney issues, okay? I'm going to skip this. You can do this in the lectures if you want to. I actually think Dr. B might give you some of this later on. So clearance summary, inulin is filtered, not reabsorbed. That gives you your filtration rate. Creatine is filtered. We did not talk about that. Don't feel bad if you don't remember that. That's just another fact for you guys. Probenecid, super cool. I left this one in because I actually learned about this. Penicillin is a great drug, a lot of resistance to it, but it gets kicked out of your body within like 30 minutes. Its half-life is insanely low, which is bad if we're treating infection. So they actually have this drug probenecid, which blocks the penicillin. It selectively binds the transporter, so penicillin can be in your body longer. Glucose is filtered, actively reabsorbed. You don't lose glucose. Urea is filtered and passively reabsorbed. Please remember the difference between these two, okay? You guys, passive, never active versus active, never passive. Your body is going to get that glucose back if it wants it. This one's really easy. Micturition, this is just how you urinate. I don't believe there's anything specific you need to know here besides everyone urinates and it is under control. You have motor control and there's also autonomic control telling you you should use the restroom, you should micturate, but you have this external sphincter here that stops it from allowing to do that, okay? Okay, so that's the end of the lecture. I hope that that was beneficial and this should be posted Thursday night, Wednesday night, so you guys have plenty of time to watch it. And that is it. I will see you in